Good day. Tuberculosis has been one of the diseases that burden our country up until now. Currently, Philippines has the highest incidence of TB in Asia. Approximately, there are 554 cases per 100,000 people. According to the 2019 TB prevalence survey, approximately 20,000 drug-resistant TB cases were recorded, 2.6 among new TB cases and 29% among previously treated cases. Good afternoon, doctors. I'm Dr. Mayuga, and I will be presenting my research titled Factors Associated with Treatment Failure in MDR-TB patients enrolled in the Pmdt clinics in the province of Cavite from January 2019 to December 2020. Pulmonary tuberculosis is a communicable disease caused by the bacteria Mycobacterium tuberculosis. It is transmitted through droplet nuclei from the respiratory tract and is the leading cause of death from a single infectious agent before the COVID-19 pandemic. Drug-resistant tuberculosis includes rifampicin-resistant TB, MDR-TB, and extensively drug-resistant TB. Included in the study are those multi-drug-resistant TB, which means there is resistance to both rifampicin and isoniazid. The study aimed to answer the question, what are the factors associated with treatment failure in MDR-TB patients enrolled in the Pmdt clinics in the province of Cavite from these time frames? So here are the objectives of the study. Specific objectives was to collect general demographic data and treatment regimen of multi-drug-resistant TB patients to compare the data with those patients who completed treatment to determine the association of treatment failure with the determined factors, to make data and findings in the study available for future programs and improvement for the PMDT in the Cavite province. The study is a multi-center retrospective observational study which conducted a review of patient records at the PMDT centers of the province of Cavite who were enrolled from the said time frame. This figure shows the schematic diagram of the study. The target population, MDR-TB patients, and patients without treatment failure and treatment complete were selected and had their charts reviewed. The study was conducted in the province of Cavite with a population approximately 4 million. It is the most populated province in the Philippines. 6 PMDT centers were designated to manage MDR-TB cases, and they are as follows. Included in the study are those patients 15 years old and above enrolled in the PMDT from January 2019 to December 2022, bacteriologically confirmed TB with the outcome of treatment complete and treatment failure. Excluded in the study are those 15 years old and below enrolled before January 2019 or after December 2022 clinically diagnosed MDR-TB, and those who do not fulfill the criteria treatment complete or treatment failure and other MDR-TB outcomes. This study is in compliance with the Republic Act 10173 or the Data Privacy Act of 2012. Let's move forward with the results. So we go back to the research question. Which of the following factors can be associated with treatment failure among MDR-TB patients? So upon the retrospective review of the charts, the following were not associated: gender, age, area of residence, smoking, and the presence of comorbidities. What is associated, according to these studies, is the socioeconomic status, TB regimen, HIV status, and the presence of previous TB treatment. So we go to them one by one. First is the socioeconomic status. This table shows us the socioeconomic class of MDR-TB patients. Most of the treatment failure patients belong to the category D socioeconomic class, while those from the treatment complete group was classified as a higher category C. P-values show that there is an association between socioeconomic class and treatment failure, where a lower socioeconomic class can be associated to a higher likelihood of treatment failure. A similar study by Topasi et al. Showed that most of the MDR-TB patients, both those who were lost to follow-up and those who completed treatment, were category C and below, but the study failed to establish association between social class and the outcome lost to follow. Next factor associated with treatment failure is the choice of TB regimen. So this table shows us the TB regimen utilized during the treatment of MDR-TB. Most of the treatment failure cases were given the newer SSOR regimen, compared with those cases who completed treatment where majority of patients utilized the older SSTR regimen. The association was statistically significant, and hence the choice of treatment regimen, particularly the newer SSOR, can be associated with treatment failure. However, recent studies on MDR TB treatment outcome showed that the SSOR, the newer regimen, had success rates comparable with SSTR, in which cure and completion rates were both high. So currently, these are the available treatment regimen for MDR TB. The newest is SSOR, and the older SSTR, SLOR, and ITR. Next factor associated with treatment failure is HIV status. This table shows us the HIV test status of the participant. HIV result of most of the treatment failure cases were not recorded, while mostly negative for the treatment complete cases. Chi-square analysis showed significant results. However, we cannot totally associate HIV test results with treatment failure since data on HIV status were missing upon patient chart review. Hence, we can only associate treatment failure in MDR-TB patient with an unknown HIV status. Similar study described that HIV status and its correlation with treatment failure. Most cases in the study had either missing HIV tests or the test was not done. So it was similar with our study. We go to the last factor associated with treatment failure, which is the presence of previous TB treatment. This table shows us the presence of previous TB treatment in the participants. Most of the treatment failure cases had no previous TB treatment, hence had MDR-TB as their primary TB diagnosis. While treatment complete patients had previous treatment, mostly with drug-sensitive tuberculosis. Based on the computed p-value, we can associate that the absence of previous TB treatment with treatment failure. We can correlate this with poor health-seeking behavior of MDR-TB patients whose outcome was treatment failure. Now we proceed with our conclusion. Medical aspects that contributed to treatment failure in MDR-TB patients in the province of Cavite included the choice of treatment regimen, absence of previous PTB treatment, and low socioeconomic status. The study concluded that the choice of the newer SSOR compared with other treatment regimen was associated with treatment failure among MDR-TB patients. Low socioeconomic status, particularly category D socioeconomic status, was associated with treatment failure. The absence of previous PTB treatment was also associated with treatment failure. There was no statistical significance with other factors, including age, gender, place of residence, and smoking. Although not statistically significant, most of the treatment failure cases had no known comorbid condition and thus no previous PTB treatment, which can be attributed to the poor health-seeking behavior observed in the patients who failed MDR-TB treatment. The main limitations of the study is its descriptive nature. Hence, inferential statistics to determine correlation and statistical significance was not done. A case control or a cohort study to analyze these medical aspects is recommended, and a larger sample size or study population would yield a more accurate results. Thank you very much for listening, and here are my references for this presentation. Thank you.